Hello, boys and girls. Our talk here is going to be on gestational and chronic hypertension. So this is high blood pressure during pregnancy, and these are some of the more common hypertensive disorders of pregnancy. Absolutely nothing to shake a stick at. You are going to run into this frequently if you regularly deal with pregnant women. So in a family practice setting, in an OB setting, you're going to see this. About 1 in 25 women who are pregnant have some kind of hypertensive disorder of pregnancy. About 3, 4, 5%. Okay, so please be aware of this. It will come up on the test. One of these hypertensive disorders of pregnancy will come up on the test at least once, I guarantee you. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. I put a link below in the description of the video, as well as there is an I button on the upper right hand corner of your screen. You can click that and consider pitching in $1 a month. A little bit goes a long ways to help keep these videos free. Thank you very much in advance. So we're going to talk about gestational chronic hypertension. And the reason that these are important is not only do these cause some complications, but they can also herald the development of preeclampsia. And preeclampsia has its own complications, these disorders known as eclampsia and HELP syndrome, as well as some more ominous things like placental abruption and seizure and all of these things that are very, very problematic for the pregnancy. So that's why it's important to pick out the women who have gestational and chronic hypertension, because you'll want to keep a special eye on them later on in the pregnancy when preeclampsia can rear its ugly head. This is a way of just kind of conceptualizing these different disorders. Really, this is the nomenclature that really trips people up. So understanding the most important fact is, okay, a woman has high blood pressure. When was it diagnosed? Was it diagnosed after 20 weeks gestation or before 20 weeks gestation? The 20 weeks is the halfway point of the pregnancy. So if you know when it was diagnosed for the first time, then you'll know if this is gestational or if this is chronic. And I could see a USMLE question telling you, woman comes in at 16 weeks and 3 days, and she has a blood pressure of 145/90. What's the diagnosis? And gestational hypertension and chronic hypertension will both be answer choices, and you'll need to know when that cutoff is. So that's at 20 weeks. So let's talk about blood pressure during pregnancy. What happens with blood pressure during pregnancy? It goes down. Okay, why does it go down? Well, the cardiac output goes up, and that's because you have a higher vascular volume. The vascular volume goes up by about 50%. But the systemic vascular resistance goes down. And when you plug in all the math, the systemic vascular resistance kind of overshoots the increase in the cardiac output, and that's going to result in a decrease in blood pressure. And that blood pressure is going to decrease during the pregnancy up until about the halfway point of the pregnancy, and then it'll start to climb back up. But at no point during the pregnancy should the blood pressure ever go back to, ever exceed, I should say, should it ever exceed the pre-pregnancy baseline. So if she runs around 120/80, let's say average, her blood pressure should not go above 120/80. It should always be at that or lower. Okay, so pregnancy is low blood pressure, lower blood pressure than normal. And that helps to get some of that blood to the placenta. Hypertensive disorders of pregnancy are the leading causes of preterm delivery. That is important. That is one of the major complications of hypertension during pregnancy. Okay, so gestational hypertension is 3 things, and I sum them up here in one sentence. So it is sustained elevation of blood pressure, and we consider elevated blood pressure to be over 140/90 after 20 weeks of gestation, in the absence of proteinuria. So first off, I want to point out that when we consider the blood pressure to be high, it can either be systolic or diastolic. It doesn't have to be both. So if a woman is running 145/85, that's high blood pressure. If she's running 130/95, that's high blood pressure. Okay, so it doesn't have to be both these numbers elevated. It can be one or the other. Okay, so it needs to be a sustained elevation of blood pressure, meaning just having one high number, just having one high reading, does not diagnose hypertension. So ideally, what you want is to have one reading and then have another reading more than 6 hours after that. Typically, that's not done in practice. You'll read it again in 15 minutes or 20 minutes, but you need to have at least 2 readings, and ideally more than 6 hours apart. Another thing to keep in mind is that if she comes in, let's say she's an appointment at 10 a.m., and she just had a big Starbucks coffee half an hour ago, then her blood pressure might be falsely elevated. Or, well, I mean, it is elevated, but it may not be because of actual hypertension. It may be because of the caffeine. So you want to make sure and ask her if she does have a high blood pressure, did you have any caffeine, any coffee, any Mountain Dew before you came in? So make sure that that is not the case. Also, make sure that it's not white coat hypertension. A lot of times, patients will tell you this. They say, oh, I always run high when I'm around a doctor or a nurse, I get nervous. If that is the case, you can have her take her blood pressure at home, and it should be normal at home. Okay, now if she has hypertension, it'll be high at home because her hypertension doesn't care where she is. So that's something that you can do as well. This needs to be a sustained elevation of blood pressure. It also needs to be after 20 weeks gestation. So 20 weeks and 0 days or later. Okay, if it's before 20 weeks, it is not gestational hypertension. Gestational hypertension has to be diagnosed for the first time after 20 weeks gestation. And then finally, this is the most important part that I want you to get out of this here. It needs to be in the absence of proteinuria. You are going to get a dipstick urine at every visit when she comes in, especially after 20 weeks. And when you get that dipstick urine and you look for protein, there shouldn't be any protein in the urine. Particularly the number that we're looking at is 300 milligrams. It should be less than that. If it's 300 milligrams or more, it is not gestational hypertension. This is a totally different diagnosis. Okay, so sustained elevation of blood pressure after 20 weeks gestation in the absence of proteinuria. So 2 things. It is important to distinguish gestational hypertension from chronic hypertension, which we're going to talk about on the next slide. Chronic hypertension is diagnosed before 20 weeks of gestation. So it may be even before the pregnancy. She might already be on antihypertensives. If you diagnose it during pregnancy, it's not gestational hypertension. Or if you diagnose it at 12 weeks, it's not gestational hypertension. Even though you noticed it for the first time during the pregnancy, it's not gestational hypertension. Gestational hypertension is diagnosed after 20 weeks gestation. So one thing you might ask is, did the woman have hypertension before the pregnancy? A lot of these women will. Okay, a 35-year-old woman, she's already on medications for hypertension. Well, then you don't even need to worry about diagnosing gestational hypertension. You already know she's got chronic hypertension. Also, very important to distinguish gestational hypertension from preeclampsia. And preeclampsia is what you would have if you have hypertension with proteinuria. So this is why you get that dipstick urine protein. Now, if a woman has hypertension and her dipstick urine protein comes back negative, you can't always rely on that. If it comes back positive, boom, diagnosis of preeclampsia. If it comes back negative, though, it may still be preeclampsia. And so if the patient is hypertensive, you may just want to get a 24-hour urine protein to be sure. 24-hour urine protein is the gold standard for diagnosing preeclampsia. We're not going to talk about preeclampsia in this lecture, but I do want to bring it up because it's an important differential from gestational hypertension. So some of the risk factors for gestational hypertension include having had gestational hypertension before, having chronic kidney disease, having an autoimmune disease, particularly lupus, diabetes, this being the first pregnancy, being older, age of 40 years or older, BMI of over 35, which would be well into the obese range, a family history of gestational hypertension, or this being a multiple pregnancy if she's got twins on board. Now, chronic hypertension is the exact same definition as gestational hypertension, with one big difference. Chronic hypertension is diagnosed before 20 weeks gestation. So it may be before the pregnancy, or maybe she comes in at 12 weeks gestation and you find out that she's got high blood pressure. That is chronic hypertension. That is not gestational hypertension. Similar to gestational hypertension, there's this big caveat. It needs to be in the absence of proteinuria. So, very important to distinguish chronic hypertension from preeclampsia, and that's all going to be reliant on the protein in the urine. So you'll get a dipstick urine protein. If the dipstick comes back positive, then she's got preeclampsia. And not only is this preeclampsia, but we would call this chronic hypertension with superimposed preeclampsia. What that means is that she's got hypertension, but now she's also got preeclampsia. She had hypertension before the preeclampsia developed, because preeclampsia technically cannot develop until 20 weeks. So that's why we have a special name for that. Now, again, the same kind of caveat applies to this as well. If you have a negative dipstick urine protein, you may still want to get the 24-hour urine protein because you may have a false negative. If you have a positive dipstick urine protein, then you don't even need to worry about getting a 24-hour. You have a diagnosis, in this case, of chronic hypertension with superimposed preeclampsia. But if it's negative, you may still want to get a 24-hour urine protein to definitively rule out the existence of preeclampsia. If the woman was diagnosed with chronic hypertension for the very first time during this pregnancy, you may want to evaluate her for causes of secondary hypertension. So that could be things like hyperthyroidism, so you may want to get thyroid panels. That could be something more rare and exotic, like a pheochromocytoma. It's not common for women, especially young women of childbearing age, to develop hypertension, especially if this woman is not obese, if she's otherwise fit. Not common for women to develop chronic hypertension. So you may want to evaluate her for causes of secondary hypertension. This is exactly how you would treat any woman who is younger, doesn't have really any major risk factors for hypertension. You want to look for causes of secondary hypertension because primary hypertension is just not common in young women. So the complications of gestational and chronic hypertension. Note that they are the same complications because all of these things are caused from high blood pressure. It doesn't matter when you developed it. These are just things that arise from having high blood pressure during pregnancy. So intrauterine growth retardation caused from decreased perfusion to the placenta. That's going to result in a small for gestational age infant. It can result in the development of preeclampsia. People who have high blood pressure during pregnancy are at increased risk of developing preeclampsia. So you want to keep a special eye out on these women. As a matter of fact, women with chronic hypertension during pregnancy, almost around 50% will develop preeclampsia. And it may actually even be more. So it may be more likely than not that she's going to develop preeclampsia. But preeclampsia may not manifest until later on in the pregnancy, or it may even develop after the pregnancy. Abruptio placenta. One of the biggest causes of abruptio placenta is hypertension. Preterm delivery, fetal demise, and maternal malignant hypertension. This would be a sudden, acute increase in blood pressure that can result in some very serious life-threatening complications, including cerebral hemorrhage, cardiac decompensation, and renal failure. So what do we do to manage gestational and chronic hypertension? First off, the management is the same because the complications are the same. The pathogenesis from the hypertension is going to be the same as far as what it can cause, so the management is the same. The very first thing you're going to do is you're going to get baseline labs. You want to get a CBC, a CMP, a urinalysis, and a uric acid. Why do we do this? Well, the reason we do this is because she may develop preeclampsia later. Okay, maybe we're at 20 weeks right now, and we know she doesn't have preeclampsia right now, but she may develop it later, and oftentimes they do develop preeclampsia later in the pregnancy, towards 32, 34, 36 weeks. We want to have these baseline labs because with preeclampsia, you can have some disturbances of your platelets, of your liver function tests, and we want to know what the baseline is. We want to know what she's at while she doesn't have preeclampsia, so if she does develop preeclampsia, we can see if there are any changes. Another reason why we get this is because with chronic hypertension, you may already have some abnormalities of the urine protein because there may be some subclinical renal disease actually already present, and that has nothing to do with the preeclampsia, if it's there, and so you may falsely diagnose preeclampsia. The uric acid level is a really good marker for preeclampsia in patients who are chronic hypertension. The level is about 5.5. If it's above 5.5 milligrams per deciliter for uric acid, then she's probably got preeclampsia, regardless of the urine protein, which will probably already be high, but it's the uric acid level. It can be very valuable to you if the patient has chronic hypertension and you're looking for preeclampsia. So that's why we get uric acid. As I already mentioned, you may just want to get a 24-hour urine protein regardless of the dipstick results. If she's got a negative dipstick, there's a very high false negative rate with that, so you may want to just get a 24-hour urine protein. If she's got a positive dipstick, 1+ or more for protein, then you don't need to do a 24-hour urine protein. Then she's preeclampsia. But just because you have a negative dipstick does not mean she doesn't have preeclampsia. You probably want to get a 24-hour urine protein just to be sure. Now, that it doesn't work the same way if she's not hypertensive. If she's not hypertensive and her dipstick is negative for protein, you don't need to get a 24-hour urine protein. This only applies to the hypertensive patients. Now, what about treatment? You may have seen on the wards some doctors just throw antihypertensives at anybody who has hypertension during pregnancy. So anybody who's over 140 systolic or over 90 diastolic. That's actually not recommended. We only treat patients, it's only recommended to treat patients who have severe hypertension, meaning that they're over 160 systolic or over 110 diastolic. And the reason for that is that studies have shown that there are no benefits to giving antihypertensives to women who are in that mild range, between 140 and 160 systolic and between 90 and 110 diastolic. There's no benefits. The benefits only come by lowering the blood pressure to 160 over 110. There's no benefits going below that. So what do we give? Typically, we give labetalol or nifedipine. And labetalol, I would say, is the most common. There's 3 drugs that are commonly used. Labetalol, which is a beta blocker, nifedipine, which is a calcium channel blocker, and then another drug called alpha-methyl dopa. And methyl dopa is not given very commonly anymore. Labetalol and nifedipine are given most commonly. On the USMLE, you will not be asked to choose between those 3. Only one of those will be the correct answer. What they'll probably give you are some obvious wrong answers, like they may say lisinopril. Well, that's an ACE inhibitor. Can't do that during pregnancy. They may give you losartan. That's an angiotensin receptor blocker. Can't do that during pregnancy. Or they may give you something like hydrochlorothiazide. Typically, we want to avoid diuretics during pregnancy. So only one of those will be the correct answer, and it will probably be labetalol. That one it's in vogue these days. The target blood pressure is between 120 to 160 systolic and 80 to 110 diastolic. So we don't want to go too low, because if we go too low, we'll reduce perfusion of the placenta. And so we don't want to go too low with the blood pressure. That's very important. So we're really only lowering it below 160 over 110. We don't want to go too low. We just want to get her out of the severe hypertension range, which is above 160 systolic or above 110 diastolic. Another thing that you need to do is fetal surveillance. Now, you will not be asked exactly what kind of fetal surveillance you need to do. You may be asked that you need to get a non-stress test and that you need to do serial sonography, but as far as the timing of it, there's a lot of disagreement. So this is what I was taught by my attending when I took my OBGYN rotation, and I think this is probably most common practice, and that is to get a non-stress test every week after 28 weeks and to get serial sonography every 3 weeks after 28 weeks. And that's what I was taught, but that's not universal recommendations. If there is evidence of intrauterine growth retardation, and that you will pick up on sonography, meaning below the 5th percentile, then your next step is to get an umbilical artery Doppler, and that is universal recommendation. And what you're looking for on umbilical artery Doppler is you're looking for end diastolic flow. End diastolic flow, meaning how the blood is moving through the umbilical artery after diastole. The blood should always be moving forward. Even after diastole, even though the blood slows down, it should still be moving forward. If the blood stops, or if it goes backwards, then you have a big problem on hands and you need to think about delivering the baby. But the blood should always be moving forward, and that's what we're getting the umbilical artery Doppler for. You're looking for the speed of the blood, so it's called velocimetry. The baby can be delivered after 38 weeks as long as there are no maternal fetal complications. The only time you're going to deliver that baby before 38 weeks is if there's maternal fetal complications. So, for instance, if there is poor perfusion to the placenta, if there's intrauterine growth retardation, which would indicate poor perfusion to the placenta. In those cases, you would want to deliver before 38 weeks, but otherwise you want to wait to 38 weeks, and that is term. And then this is very important as well. You need to follow up in 12 weeks, and when I say 12 weeks, I mean 12 weeks after delivery, to ensure a return to baseline. In gestational hypertension, that's only hypertension during the pregnancy. So after 12 weeks after delivery, by 12 weeks after delivery, that hypertension should have gone away. She should return back to baseline. Now, it's not going to happen right away, but within 12 weeks after delivery. So you'll follow her up 3 months after she gives birth, and you want to just make sure that her blood pressure has returned to the normal baseline. Because if it hasn't, her new diagnosis is chronic hypertension. And so then when she goes on in subsequent pregnancies, you already know she has chronic hypertension. That will stick with her for life, that diagnosis. Okay, so follow up in 12 weeks. And this is only if she's got gestational hypertension. So if she was already diagnosed with chronic hypertension, then you don't really need to do that. But if she was diagnosed with gestational hypertension, meaning you picked up the high blood pressure for the first time after 20 weeks, then you want to follow her up 12 weeks after delivery to ensure that her blood pressure has returned to baseline. And that's all I've got for you for gestational and chronic hypertension. I will see you next time.